All right, why don't we get started? I'd like to welcome you all to the CITRIS Distinguished Speaker Series. Sorry, I need my little... There we go. As you all know, we typically webcast all of our Distinguished Speaker Series and our research exchanges to our remaining sister campuses at Merced, Davis, and Santa Cruz, and this is no exception, so welcome to everyone out there. This talk is actually a very interesting one in the field of public health. We're very pleased to welcome Dr. Jamie Kaufman today, and it's my pleasure to introduce him. Dr. Kaufman is the manager of healthcare research project in the Department of Computer Science at IBM Almaden Research Center. He received his bachelor's in physics from Cornell and his Ph.D. in physics from UC Santa Barbara, so another UC alum. He's a fellow of the American Physical Society, and during his career at IBM, and this is actually what I find most fascinating, he's made contributions to several fields from magnetic devices to pattern formation, conducting polymers, diamond-like carbon, superconductivity, and experimental studies of the moon illusion, and contributions to distributed computing, privacy protection, and grid middleware. You might wonder how he ended up in public health, which I think is, I was actually gave me a very nice story about that. So his current interests include public health and interoperable health information infrastructure and spatiotemporal epidemiological modeling. So his group is currently working on the Eclipse Open Health Framework as a modeling framework for public health. Please join me in welcoming Dr. Kaufman.
Thank you very much. Ravi, thank you for inviting me. Is the volume too loud? You guys good? Okay. So this work that I'm going to talk about today, actually I think it's a bit loud. There we go. This work that I'm going to talk about today is a collaboration of many people across 3 labs. IBM Research is a worldwide organization, and so the work that I'm going to discuss was done in my group at the Almaden Research Center, also with Boaz Carmeli's group in the Haifa Research Lab, and also some colleagues at IBM's Watson Lab in New York. Before I can talk about public health, I want to say a little bit about healthcare. In most of the world, there's no division between public health and healthcare, but in the United States, we have a private healthcare economy for individuals and patients, and then we also have public health organizations. We got into this field of healthcare in IBM Research really looking at clinical care and the need for electronic health records. As many of you know, the US spends actually now over $2 trillion on healthcare. That's more than twice the per person cost of any Western nation. And half of that cost today comes from government. So we already have a government healthcare for some of our population, and it costs about $1 trillion a year. So one could, for instance, transform that into the healthcare system of Canada without raising taxes, if you wanted to. I'm not advocating it. So today, Medicare and Medicaid make up the largest or second largest line items on the budget of every state of the union because the dollars flow through the states. Despite this huge expense we make, people die from avoidable medical errors in the US at a rate that's been estimated to be about as high as 150,000 deaths per year. If that number is correct, that's equivalent to crashing 1 jumbo jet per day. Imagine if the airline industry did that. There'd be some desire to take action, corrective action. One of the things people have looked to do to improve healthcare in the United States is to have an electronic health record. In order to do that, we need to have interoperability between all of the many silos of information that exist today in healthcare. So computing in healthcare is a bit like computing in the 1970s, which is before many of you were born, but there were many different systems and they didn't talk to each other. If we had interoperable healthcare, one could imagine it would really do wonderful things for medicine. So here I've got a little cartoon of all of the sources of data in healthcare today, all of the instruments, the laboratories, the labs, the pharmaceutical entities. If we could transform that data into some representation that could be understood both by people and by machines and moved around in accordance to some set of standards, then your entire population would become potentially part of a research trial. You wouldn't have to wait 10 years to suddenly discover that 2 drugs used in combination are having an adverse effect. You'd have immediate feedback. And it could be used, therefore, from research to synthesis of new drugs, and essentially transform medicine into a science. And I like to make an analogy to the internet. What would it take to have an internet in healthcare? To create the internet, we need a number of things. We need web servers, so you need hardware, you need machines. You need some set of standards, HTML, HTTP, but you also need free browsers. And so the barrier we have to find ways to lower the barrier to using the standards. And in the internet, it was the free browsers, and I'm going to suggest what we might need if we want this kind of a model for healthcare. There's an organization called the IHE, Integrating the Health Enterprise. They're not a standards body. They're sort of a consolidator of standards. So people will sometimes say, we lack standards in healthcare, but in fact, there's no shortage of standards. In some ways, there may be too many. But what IHE does is it looks at the standards as they exist today and describes how you could combine them and harmonize them to achieve interoperability in healthcare. And here you can think of interoperability as enabling a conversation. So it might be a conversation between a doctor at some small clinic with a system that might sit in a hospital. And so the IHE describes how to take these standards and comes up with examples of how to implement them in technology. The IHE started out as a U.S. entity. Its offices are in the RSNA, Radiological Society of North America, but it's now, over the past few years, become an international organization, and IHE runs events called Connectathons and interoperability showcases worldwide. There's an IHE Asia, North America, and Europe, and the subdisciplines are in radiology, cardiology, oncology, IT infrastructure, laboratory, et cetera. The good news is that not only do the standards exist, but they're tested every year. So the Connectathon is a test that IHE runs in the winter in a big basement in Chicago, and over 50, actually last year, over 70 vendors participated in this event. So these are the big software companies that make medical record systems for hospitals or laboratory information systems. And they go there to this basement in Chicago, and they test their software, and they prove that they can send data according to these standards from one system to another. And the prize, if you can pass the Connectathon, is you get to go to HIMSS. And HIMSS is the largest marketing event in healthcare in the world. There was about 30,000 people that attended this event in San Diego in 2007. And you can see pictured here at the Interoperability Showcase many of the big vendors in healthcare, each playing different roles. And in some sense, this showcase is like a model of how information could be exchanged if everyone were to use the standards. So the companies have the technology to do this. The bad news is they're not selling it because they have no reason to sell it. But the idea I wanted to get across here is simply that there is no technical obstacle to having an electronic health record. It's going to take regulation and overcoming barriers, but it's not a question of invention. This is the picture of how people thought we might have interoperability in healthcare in the United States. This is different than in a country where you might have a single payer system. But in the US, we have private care delivery organizations, which might be hospitals, it might be an HMO, it might be a small clinic. And within some region, a number of these organizations need to share data because their patients move from clinic to hospital to lab, and their doctors may be associated with more than one institution. So there's a need to move data around within a region, and so the IHE calls this a clinical affinity domain. And they imagine that within each clinical affinity domain, the care providers will share an infrastructure which is called a RIO, a Regional Health Information Organization. I think of that as a health record bank. The health record bank might be a repository of data, or it might just be a pointer to where the data is. It might be a federated system. You might have many of these regional banks and they connect together in a larger network, or it could be the health record bank for a single country. So the technology will support many different models. In the US model, we talk about a clinical affinity domain, which might be the Bay Area or a collection of providers in some region. The way this conversation takes place, the standards don't require, and HL7 do not impose a data model. So a vendor is allowed to store data in their system in whatever representation they want. They simply, the standards say, as a transport, you should represent it according to some schema, some XML schema. And so any application simply has to use one or two interfaces, which are document source and document consumer. So if you have an application that can be a source of data, if you implement the document source interface, then you can go to the Connectathon and comply with the standards. You can implement other interfaces too. The standards simply say, do this one. And so in addition to the document source and document consumer, there are interfaces that exist at the level of the bank, and that would be, those are listed above. There's a registry or repository, and in particular in the US, you need something called a PICS, PDQ, which is like a master patient index. Even within a hospital, there could be many systems that represent a patient with different IDs. And so if you have no unique ID, you need to be able to resolve them. So once in research, we became aware of these standards, and we wanted to see what we could do to lower the barrier to companies and people embracing the standards. Obviously, from an IBM point of view, the idea of a standard for the health record bank would be a great one. If we had an electronic health record, that layer in blue could be IBM hardware. It could be somebody else's hardware too, because it's standard, but it would become a good business to be helping with that exchange of information. IBM probably doesn't think of itself as the bank, but banks are good customers, and so we could sell technology to banks. But you have all this world of application developers in medicine. Not all of them know how to speak the standards. And so that's where, as a research organization, we wanted to create a layer using open source that would hide the complexity of using the standards. How many people here know what XML is? Raise your hand if you've heard of XML. Great. So if you're writing a program in Java and you want to parse an XML document, you don't go to some big reference and read 10,000 pages on what an XML parser should do. You simply download an XML parser from Xerxes. So similarly, we can use open source to create tools that implement these different interfaces from the IHE, for instance, document client, document source. And then in addition, we created something called the OHF bridge, which further hides the complexity from the user. So a company that might want to write a personal health record like CapMed could download this, use the OHF bridge, write a couple of lines of PHP, and be able to export their data according to the standards. In 2006, the US Department of Health and Human Services issued a request for proposals and ultimately 4 contracts to prototype an NHIN, what they called the National Health Information Network. IBM actually won one of these contracts, and they used the technology from research both for the bank and also to network all of the applications that existed in 7 hospitals and 24 clinics that were participating in the IBM demonstration. All 4 were successful, and at least 2 of them used the standards that I just described. In IBM's case, there were actually 3 clinical affinity domains that were created. There was an organization, RIO in New York, in Virginia and North Carolina, and in Pinehurst, North Carolina. And interoperability was demonstrated both within the RIOs and also between the RIOs, because you do have people that will move from state to state, and we need to be able to move records between those organizations. Well, that was great. That demonstration was done, but I was told by somebody who was in the room when Karl Rove and David Brailer and George Bush were discussing the idea of an EHR, and Brailer had suggested to Bush that they actually put in place an electronic health record system in 18 months. Bush agreed, and then Karl Rove said, no, let's do it in 10 years. So after the successful demonstrations, nothing happened. There was really essentially no follow-up. And so we were trying to see what else we could do to lower the barriers, again, from an IBM Research point of view, to acceptance of the standards. And we became very interested in the domain of public health. The data that's required to protect populations comes from individual patient records. Today, when CDC wants to gather data, there have been many projects to try to do this. They've created many different repositories, each of which is like a database application and ultimately becomes its own silo of information. So we're creating interoperability problems in public health. The 80 labs, the public health labs in the United States use about 80 different coding systems to exchange data. So this is a huge problem. But why not try to use these same standards? IHE was not thinking about the public health use case when they came up with what I just showed you, which is called XDS, the Cross-Enterprise Document Sharing Profile. And so we wanted to see if we could use that XDS clinical profile for public health. And so just like we have a clinical affinity domain, one can talk about a public health affinity domain. The IBM naming people wouldn't let me use Ph.D. I had to put an I in because somebody else was using that acronym. But the basic idea is that you have a collection of private and public organizations that need to work together under a common set of policies and infrastructure to share public health data. And just like the RIOs can be organized hierarchically, so too could the public health affinity domains. You might have data that's collected at a state lab, and that might have to roll up to the national CDC, and then the national CDC might want to report into the World Health Organization. So you've got a hierarchical structure. So we went ahead and we actually built a prototype using the infrastructure we created for NHAN for public health. And about that time, we became aware of an organization called MECIDS, the Middle Eastern Consortium on Infectious Disease Surveillance. MECIDS is a collaboration between the Ministries of Health of Jordan, Israel, and the Palestinian Authority. They were already in existence. They are funded by the Nuclear Threat Initiative, or NTI. So NTI is a nonprofit that was founded by, and its president is former Senator Sam Nunn. And NTI originally wanted to help countries come to an understanding that they don't need and shouldn't have nuclear weapons, but it wound up being difficult to get countries to engage in that dialogue. However, it was easy to get countries to discuss exchange and cooperation in public health. And so NTI formed something called the Global Health and Security Initiative, which funds MECIDS. The goal of MECIDS is to establish regional cooperation on disease surveillance, to build a capacity to deal with disease outbreaks, and to build relationships to manage cross-border cases. They were initially focusing on 2 foodborne diseases which were an immediate problem, Salmonella and Shigella. And there is tourism. People are traveling from Amman, Jordan, to Tel Aviv or Jerusalem, to the West Bank, to Gaza. And often you'll have somebody show up with food poisoning, but they got the food poisoning somewhere else. So they were already sharing data. Unfortunately, they were sharing the data by paper, by Excel spreadsheet or fax, and it was taking about 2 months to analyze the last month's worth of data. So when we learned about their work, we asked if we could present to them an idea. So we came to one of their meetings, which was held in a little shack on the Jordanian side of the Allenby King Hussein Bridge. So we had left Israel, but we had not yet entered Jordan. And we proposed to them the idea of using this technology to help them exchange data in public health. And so we went ahead and we built a prototype working with them. We then reviewed the technology in Lagode in the summer of 2007, and then have had deployment workshops now in Amman, Jordan, and East Jerusalem. And they have a system now deployed for each country, and then another system for international communication, which I'll show you. So again, MECIDS was established to support national and international surveillance and to provide regional cooperation. They wanted to have a capacity to deal with disease outbreaks. They've recently expanded this from Salmonella and Shigella to avian influenza. And they also want the relationships to manage cross-border cases. So when somebody gets sick in Gaza and needs to go to a hospital in Israel, there are people on both sides that make that happen. So the people involved in MECIDS from all three countries are medical professionals. Most of them are doctors. Some of them are masters of public health. The system we built for them handles the use cases they were concerned with, but it's designed to be easily extended to handle other diseases because it's not a silo. Now, one can ask, why do the MECIDS countries cooperate? Who can identify this picture for me? Anybody? Yes? Yes. Good one. So this is the Liberty Loan Parade that took place in Philadelphia in September of 1918. The Spanish flu had already broken out, and public health officials had warned the city not to have this event. This was a fundraiser for World War I. It was considered unpatriotic not to attend. In fact, if you didn't come and if you didn't give money, you were harassed in all sorts of different ways. Look at how deep people are packed. Everybody showed up for the parade. And within 1 month of this parade, 100,000 people in Philadelphia had died. So that's how quickly the avian influenza struck. More soldiers died from Spanish flu. More soldiers died from Spanish flu than died in combat in World War I. So you might imagine that public health should be attended to as a matter of national security. If you think about the number of people that could be affected, new diseases are entering the human population all the time. The reservoir for most emerging infectious disease is the animal population, and when something like the flu needs to do three things to become a human disease. It needs to hop between species, it needs to reproduce inside your cells, and it needs to transmit easily between members of the new host species. If that happens, and if the host population is fully susceptible, you get something like the Spanish flu. That kind of thing seems to happen about once a century, kind of like big depressions. And so if you took the numbers from the Spanish flu and simply translated that to the US population today, you'd be looking at almost 2 million people dying in a period of about 3 months. So that's about the number of deaths you'd have in a year compressed into 3 months. But you can do things about it. In 1918, the west coast of the US had significantly fewer deaths. There are a few reasons for that. We had a well-established public health policies in place after the earthquake of 1909. And we had warning, so we knew it was coming because things happened more slowly back then. So having good public health policies and having warning, having proper communication, can let you put in effect policies and decisions that will protect your population. That's why the MECIDS people cooperate. All right? They're medical doctors, they understand public health, and they want to protect their people. So it's self-interest. This is a salmonella storyboard that'll help see how you'd use the technology in a public health scenario. So a patient shows up sick. A doctor suspects salmonella, takes a sample and sends it to the local laboratory. In the case of MECIDS, each country has 8 to 12 Sentinel Laboratories. These are located mostly at the hospitals, and they would do the initial identification of the pathogen. The lab determines, yes, this is in fact salmonella. They'll send a report. That report can go back to the original doctor, but in the case of reportable infectious disease, it can also be sent to a Ministry of Health or some other organization. In addition to that simple storyboard, there is in each country a central laboratory that does more advanced testing, for instance, serotyping or measuring antibiotic resistance. So this is a picture of MECIDS and how they're organized. Each country has laboratories. These are the Sentinel Laboratories. Typically, they're located in hospitals. The Sentinel Laboratories will send, and the policies are different in the different countries, but the technology really doesn't care. Sometimes the data will flow directly to CDC. Sometimes it will flow to the ministry. They each have their own way of doing the reporting. And ultimately, they have decided that of the full patient data, some subset of that data will be shared internationally at the Cooperative Monitoring Center in Amman, Jordan. And so regardless of how the data flows, with one IHE repository, we can have clinical providers send patient data to the repository. They're sending salmonella isolates to their public health laboratory, which is doing identification, and they can then retrieve the clinical data, add information to it, and update the record inside the repository. And then the Cooperative Monitoring Center in Amman can be watching this at some higher level, looking at the aggregate data and asking, okay, is there an outbreak going on? This is how XDS works from a clinical point of view. Here, John Doe has come to his doctor for a routine physical. According to the IHE, that doctor, who is running some kind of electronic medical record system in his clinic, will submit data about John Doe, both a document and metadata, to a repository. The metadata is placed in a registry. And now John Doe also got a blood test, and so the lab can submit the blood test results to the repository. And the doctor or John Doe from his personal health record can then say, give me the records for John Doe. And that was what IHE was focused on. Really, the only query they handled was the patient. And hopefully they get back all of the documents related to the patient. In public health, we now have John Doe coming to the clinic, but he's got a case of salmonella. The doctor is going to make an initial diagnosis of salmonella and send that data to the repository and to the registry, send a sample to the laboratory, which will then determine perhaps the exact strain of salmonella, register that data. But now instead of a doctor asking about John Doe, the Ministry of Health might be saying, find me all the records on salmonella. And now I want to learn how, whether there's an outbreak or how the species of salmonella is changing in my area. So it's actually a fairly small change to the profile. Not only did we implement the system, we fed those changes back to the standards body. HITSP, which is the Health Information Technology Standards Panel, which writes the regulations in the US, has actually approved our input. And so they've extended XDS. So XDS Lab and XDS both use the same profile. The document itself that gets submitted is an HL7 CDA R2 document. So this is the XML schema. And here we can show you that that CDA document can contain not only the clinical information, but the lab can obviously read that clinical information and then add to it public health information. The MECIDS countries that we're working with asked for a web-based application. So the whole point of the standards are you have this health record bank, and now any application you want can deposit data or remove documents from it. MECIDS didn't want a LIMS, a laboratory information management system. They wanted a web application simply because for some of the countries it was too hard to maintain an IT system in each lab. Some of the countries had LIMS systems, others didn't, but they wanted to do their reporting by the web, and that way there was only one place where they needed to maintain the software. If they were dealing with paper, as is the case in some of the Palestinian labs, the data in the web application has to be entered manually by hand. But for Jordan and Israel, where they already had the ability to report with Excel spreadsheets, we gave them a simple tool that allows them to import from the Excel spreadsheet right into the system. So that then produces a human-readable view. Behind this human-readable view, there's this XML document. And that XML document contains other information coding systems. So how many of you have heard of Sno-Med? Okay, so Sno-Med is a medical coding system. There are other medical coding systems, LOINC. ICD-9 is a billing coding system. In Europe, they're using ICD-10. What a coding system does is it makes something machine processable. So you might call something a blood test in one state. Another hospital might call it a blood serum test. You can even within a language, you can have different words to describe the same medical thing. A coding system says, this is the code for what you're doing, all right? And that's international. Sno-Med is free in the United States because the US government purchased a license for the United States. In most countries, it's not free. We were able to get a free license for the 3 MECIDS countries so that they could use Sno-Med to exchange their data internationally or within the region. So obviously, we provided them with national language support, so the application works in Hebrew and Arabic as well as English. But what's more important, I think, is that behind the data is a coding system that makes the data exchangeable internationally. And then, of course, the application also allows them to do queries where they specified the public health queries that they wanted to implement. And some analytics. So we use the open source technology from Eclipse called BERT. It's a business intelligence reporting tool, and we've simply automated the reports that they were already generating in Excel, but now instead of taking 2 months to process the last month's data, they can do it at will, on demand. And the other thing I wanted to tell you a little bit about is the Spatio-Temporal Epidemiological Modeler. In the end, you're gathering data and sharing data for a reason. You want to learn something. And so the STEM is meant to support not only visualization of disease reports by location and time, but also to give the users some predictive modeling capability. And so we integrated STEM into the MECIDS application. STEM is open source. Anyone can download it and use it for free. There's no cost. You can contribute back to it if you want to. And its home is at eclipse.org. If you just go to Google and you type OHF space STEM or Eclipse space STEM, you'll find it. Right now, it's a subcomponent of the OHF project, the Open Healthcare Framework project at Eclipse. It's soon going to graduate to be a top-level Eclipse project. How many people in the audience know what a epidemiological model is, or a compartmental model? Okay, I'm going to just say a few words about it. So one way to model infectious disease, how many people have had chemistry? Okay, it's like chemical rate equations. Okay, you take your population and each person can be in one or another state. Okay, so they might be susceptible to a disease. If you mix with lots of people who are infectious, you might become exposed. And if you're exposed at some rate, you'll become infectious yourself, and then hopefully you'll recover. Once you've recovered, depending upon the disease you're modeling, you might lose immunity over some amount of time. Of course, people can be dying and people can be born. Usually they're born into the susceptible state. Sometimes people will model using these 4 states. Sometimes they'll use SIR, simpler models, or even SI models. And behind this, there are some differential equations, which are like chemical rate equations. In the past, most epidemiological modeling was done non-spatially. And partly that's because we didn't have GIS data. If you don't have data, there's not much you can do. You would just know how many people in Philadelphia, for example, died of the Spanish flu, in which case you'd create a model. It might be an SIR model, but you're saying, take the population of Philadelphia and treat them like they're in a well-stirred beaker. So the entire city or the entire country is just mixed. But in reality, people move, and people are separated in space. And so they're mixing in space and time. Every talk should have one differential equation. Let's just focus on this one. So this is the change in susceptible population versus time. In all of these models, there's typically a term that says susceptible people become exposed or become infectious by mixing with infectious people at some rate. So that's your cross term. That's the only one that matters. And if the model were non-spatial, that would be it. But in a spatial model, you have this, you have to introduce the idea of location, and you're going to obviously sum over all your locations, but now susceptible people over here can become exposed or infected by infectious people over there. So I need to introduce some model of how people are moving, Santa Clara County to Alameda County. And you can do that, and then you can solve the problem on a computer, and scientists do that today. The representational framework in STEM is that of a graph. So it's very general. It just says the world is a graph, and it contains nodes and edges. And on each of those nodes, you can put labels, like a disease or a susceptible population, and you can put decorators, which is computer code. And so the advantage to this is you can use Eclipse component software model to compose new graphs from other graphs. So you can build pieces together using a drag and drop interface. And that's a very powerful idea and very useful in infectious disease. I like to compare infectious disease to a storm moving through the ocean. A disease moving through a population is like a storm moving through the ocean. The difference is, if you want to study the weather and you want to forecast the weather, you only have to deal with one set of physics. There's one planet Earth, it's got an atmosphere, there's one set of features of the land, and if you can mathematically represent that, that model will continue to work. With infectious disease, you have a much larger range of vectors, and so the equations, the rules that you use for the propagation of that disease are always changing. The model that you use for one disease is going to be different from another disease. So this is simply a picture of viral sex. Here you've got avian influenza, which is not a human disease. It may make the leap into a human cell. And now here's a picture if we have a human individual who has the human flu and also contracts avian influenza, that RNA virus can have viral sex and exchange RNA, perhaps creating a new kind of influenza. That's not actually how they think avian influenza will wind up becoming a human disease, but this does happen for some types of RNA viruses. So the world is a graph. This is a picture of the United States and the 3,100 or so counties in the United States, and these counties are connected by being next to each other. And here I'm showing you the common border edges, but they're also connected by other things such as highways, migratory bird paths, streams and rivers. All of these things are pieces of a graph, and they can be represented and composed by adding them together. So to give you an example, let's imagine we want to make a model of not mad cow disease, but hoof and mouth disease, which is one of the biggest economic threats in agriculture. If your cattle get hoof and mouth disease, you potentially have to kill every cow in the country. I might be interested in studying hoof and mouth disease in the United States. Somebody else might be interested in studying it in Canada. So we could have two models. Each would require a knowledge of how the cattle are transported within those countries, where the cattle are fed, where the cattle ranches are, and how they're transported between the two countries, because there's trade between the United States and Canada. And of course, I need to know something about foot and mouth disease itself. I'll need a mathematical model of the disease. In the past, when epidemiologists built models like this, a graduate student would spend perhaps a year doing research on where the cattle are raised and how they move the cows. They, of course, would write a simulation and do the mathematics necessary for that simulation, and then the result is they publish a paper. With a component software model, all of this data that goes into the model, the denominator data, can be stored as what's called an Eclipse plugin, which is just an XML file. But it can then be reused. It can be shared by a community, and somebody can look at this paper that was published using this model and say, well, that all looks correct, except you forgot that foot and mouth disease can live in freshwater lakes. And so rather than having to start over, they would simply have to come up with they'd send their graduate student to spend a year finding all the freshwater lakes, and they'd simply add that graph to the model, and now they would have a new model of foot and mouth disease, and they could see how it differed from this one. And so that's the way STEM works. It's basically built on a collection of graphs which together define models, and then a model can be used in different scenarios, where a scenario might mean I have my model of the United States with all the people and how they move, and I have my model of human flu, and now my scenario is I'm going to start that flu outside of Boston, or I'm going to start that flu in Santa Cruz County, or I'm going to start that flu by taking the latest public health surveillance data from the Ministry of Health and use that as an initial condition in some simulation. And therefore, you'd like to be able to semi-automate the building of new models. So another thing STEM allows you to do is to import actual data to define what model you think is appropriate for that data, and to estimate all these coefficients, all these parameters that go into what I described as a chemical rate equation. And then, of course, do some computational work having got that as a starting point. Once you've done that, you want to know how well you're doing, because if you're really going to make policy decisions and do what-if experiments based on a simulation, you'd like to know if the simulation is any good. And so there are also tools that allow you to take data and to take, say, a time series of data. Our Israeli colleagues have 10 years of influenza data and 10 years of Shigella data, and to take a model of that and to look at different mathematical measures to say, are we doing better? Are we doing worse? Is this a good model for the disease? And then, of course, you want to know how quickly those models lose accuracy. So infectious disease and models of infectious disease define a dynamical system. Like predicting the weather, no dynamical system is deterministic. Even if you take an identical model and start it with an initial condition just that's infinitesimally different from some other initial condition, you'll eventually have a different outcome. And so the rate at which those systems diverge in a phase space can tell you how fast your models are going to lose accuracy. So you have a 5-day forecast for a reason. Given the grid and given what we know about the models of the weather, we know after 5 days the predictions aren't very good. If you can do all that, then since you have a model, unlike the weather, you can do something about infectious disease. You can put into place policies which can be represented in your model. And so you can decide, for instance, what will happen if I stop the air transportation? Or what will happen if I distribute surgical masks or do something else, and look at that. There's a group at MIT that's actually added an economic model on top of STEM in order to try to estimate the costs and the cost-benefit analysis of doing different things. Why open source? We talked about all the vectors of infectious disease. No one organization can solve this problem. No one research group can come up with a framework that will allow you to rapidly prototype every emerging infectious disease, including things we've never heard of. I suggested that the component software model allows you to share data, but it's really going to take something like a global open source community to build up and collect enough knowledge that you can do modeling on a time scale that's relevant to new emerging diseases. So we've begun that, and we have some colleagues at the Israeli CDC, at Pitt, at UPMC, Johns Hopkins, Palestine, and elsewhere. I'll just say a couple words about the Eclipse Foundation. So Eclipse is an open source organization. It uses something called the Eclipse Public License. One of the things that the Eclipse Public License does is it allows collaboration between different types of people. So unlike some open source licenses which say, if you take this open source software, everything you create with it forevermore must be open source under the same license, Eclipse allows different ways of using it. So you can take the code, if I'm in academia, I can take it as open source and use it for free. I can contribute back to it and have that covered under the same license. If I'm in industry, I can take open source code from Eclipse, add to it, and sell it if I want to. Or if I'm in government, I can take open source code from Eclipse, add my own information that I choose to keep secret and not share back. So it makes possible collaboration in different modes, and that could be important in public health. So this work was recently awarded a laureate award from the Computer World Honors Program this year. And as I mentioned, we were contributing back to the standards organizations that are writing these standards and describing how we were able to use this XDS profile in public health. In my opinion, that blue infrastructure I showed you on top, which might support an electronic health record for clinical care and for patients in the United States, it would be a great thing if we did electronic health records based on standards as opposed to going to some proprietary model where there's one company in the country that stores everybody's records. But it's probably not enough for public health because public health organizations tend to be poor. So it would be good for the world if there was an open source implementation of that health record bank. And so that's something that we've been advocating and we think would help promote these standards globally. The MECIDS prototype that I described to you is not open source right now, but you can try it out for free. So if you go to the IBM AlphaWorks Services site at this URL, you can actually go and play with it. It's essentially the same application that's running now in the Middle East, except it doesn't have the Sno-Med codes underneath. So we had to rip that out because the license for Sno-Med is not free for everyone. And this can be accessed anywhere. And that's it. If there are any questions.
So we have time for a few questions. Please wait for the microphone to come to you so the people on the webcast can also hear.
Do you see this sharing of information usable by drug companies that can track safety of recently approved drugs or even in clinical trials?
Do I see the information as being, I want to make sure I understood the question.
Can this interchange work in that application as well?
So the question is who has access to the data in the bank, right? That's not a technology question. That's a question for policy and regulation, right? Certainly, I would hope that if everybody had an electronic health record, say in the United States, that research could be done on that data. If the data is only there for the patient and the patient's doctor, that's a good thing, but it doesn't allow you to discover things like as you said, like adverse drug interactions. Who should be able to get the appropriately anonymized data to make that discovery is something that would have to be determined by policy and approval. Maybe it's the drug companies, maybe it's university researchers, maybe both. I think that's a collective decision, right? How do we want our data used?
Other questions? Jean-Paul.
Thank you. I'd like you to say more about the policy impact in everything you're saying, because technologically everything makes sense. But unless there's a policy mounted on it and a proper use and a proper authorization, a proper system of usage, all this will be put to waste. So have you thought about the policy aspects of this? MECIDS is a very controllable situation, right? So compared to the United States.
Well, I think people have to decide what they want, right? I mean, if you talk about policy or privacy, right? In finance, we all are concerned about privacy and identity theft, but most of us use credit cards, and most of us probably use those credit card numbers over the phone or over the internet without thinking too carefully about it, and people steal your identity, but we still do it. If you are most concerned about privacy, if that's your biggest concern, don't have an electronic health record. But if you get really sick, you're probably going to be more concerned about getting good treatment and getting the best treatment. So the policies are going to be different in different countries. In some countries where the medical care is paid for by the government, and some governments may decide that your data is owned by the government, right? In the United States, I think we think that our data should be owned by us, and arguably there's regulation that says that that's true. I'm not sure that your hospital or your radiology lab feels they have to hand over the x-rays, but you know, that it's a decision. Yeah. Right.
I think your answer could go beyond that, and I think also it ultimately would have to. In the case of visa is a good example. We kind of have to use visa, sort of, right? Otherwise you can't go to a hotel, you can't travel. On the other hand, visa doesn't give us any opportunity to protect ourselves. So in the United States, fortunately, the visa company usually swallows the loss from that, and then we pay for that through fees, somehow hidden from us. With these health records, I think as provider, the provider should first of all outline how really the data can be protected. And I'm sure you thought about that, right? The other thing is also that there should be some kind of an analysis or so of different scenarios and different outcomes. So sort of this cost-benefit analysis, right? If I make, for example, this data suitably protected and anonymized available publicly, what would happen? What would we gain from that? And what would we lose?
So actually, I apologize. I did not even address what technology does under IHE profiles to protect the data. So I talked about XDS only. If I were to go back, there's a slide that talks about ATNA and security and secure nodes. So the technology has built into it the same security technology you would use for a financial transaction. It also has audit trail, who accessed the data, right? So there's a difference between privacy and security, right? Security is violated by somebody walking into an office, grabbing a file out of a filing cabinet and walking out of it, right? Or a database administrator decrypting the database, reading what patient is in what room and telling it to the whatever tabloid is interested in, who's having cosmetic surgery. That's a security, not a privacy issue. There's technology to protect both, but in the end, it's regulation that's going to determine how effectively that works, right? I mean, if the penalty for violating it is not appropriate to the cost, people are going to violate it right and left. I think there always has to be an opt-out, right? I mean, there's going to be hopefully a consensus of what we as patients want, for good medical care. I would rather have an electronic health record than go to a hospital knowing that there's a 50% chance I'm going to be given a wrong drug or an incorrect treatment. But some people may not, yeah.
You make this decision based on information that perhaps through your work you have about the system. You understand what happens, what are the positive outcomes, and what are the potential negative outcomes of that decision. I think the problem is that both policymakers and end users, they normally don't have the information to make that decision. And if they're not given the information then, and in this country this works perfect, right? You scare them, and then nobody uses the system. People say that this is bad for me without knowing why it's bad for me, but it's bad, so let's not do it.
I agree with you. By the way, today, anybody with insurance, there's a record of all the treatments that the insurance company paid for, and the insurance company has that record, right? I mean, so there is an electronic health record of sorts that none of us have any say.
It's a different space, but it's this caller ID thing, right? They roll that out, and then afterwards they roll out the thing that you can defeat it. So now it's useless.
Other questions? We have time for one more.
Given the importance to national security, is there any collaboration with military or our own CDC instead of the Israeli CDC?
Are we working with the U.S. CDC? We have certainly met with them on many occasions, and we want to work with them, so we are collaborating with them. The U.S. CDC does not actually make decisions about the IT that's used in the state and local health departments. So and a colleague of mine from Google was saying it was easier to do electronic surveillance or biosurveillance in Indochina than it was in the United States, because we have created, reporting structures, and each state has done their own thing in many cases that actually make it more complicated to put something in place. The budgets for public health are small, so who has the responsibility for fixing the problem? It's going to take a big investment to do something about it.
Okay, that's all we have time for. Please join me in thanking Dr. Kaufman. Okay, we're officially adjourned. Thank you very much. You're welcome to stay and ask Dr. Kaufman any trailing questions you may have.